My pleasure and privilege to introduce Dr. Rebecca Hahn. She doesn't need a formal introduction. She's one of the most renowned experts in valvular heart disease, but briefly, she did her medical training at Washington University School of Medicine in St. Louis. She did her internal medicine and cardiology training in New York. She was appointed in different hospitals in New York. I have the New York hospitals, the North Shore. And in 2009, she joined Columbia and the International Cardiovascular Care. And she became the first director of International Echocardiography for the structural heart and valvular heart disease at Columbia. She's a full professor of medicine at Columbia. She's the chief scientific officer of the Echocar lab at the Cardiovascular Research Foundation, which is one of the most famous CRO doing trials in the world. She has dedicated her career to echocardiography and valvular heart disease. She has more than 350 publications, including one very recent publication as a state-of-the-art in the New England on the tricuspid regurgitation. 11 book chapters. She's part of numerous committees. She's participating to 4 academic research consortium documents. She's a PI also for several very important trials on devices and valvular heart disease. She has done numerous presentations and grand runs. Dr. Hahn has a very busy day today. She agreed to do the grand runs and after that to meet with the residents and after that to meet with the staff to discuss possible collaboration in research. So without further ado, I give the mic to Dr. Hahn, and thank you again for being with us today.
Oh, thank you so much. It's really my pleasure, and that's such a generous introduction. I thought today we'd talk about my favorite valve, which is the tricuspid valve, and really review some of the things that I discussed in the New England Journal article. These are my disclosures. And the story starts really with a lot of misconceptions about tricuspid regurgitation, with an initial surgical article about why we should forget the tricuspid valve. And this was a study of mainly rheumatic mitral valve disease patients who had pulmonary hypertension. And in this study, Nina Brunwald showed that with just the treatment of the mitral valve, you were able to see a significant reduction in pulmonary artery systolic pressures and then a reduction in tricuspid regurgitation. And so the conclusion was that you really didn't have to address tricuspid regurgitation, particularly in the setting of mitral valve disease, and that it was just really a passive player in the outcomes of that disease process. And so the first misconception was that TR would resolve following left valve surgery. But we know from multiple studies, and this is an older study by Jose Navia, that if you repair or don't repair the mitral valve at the time of surgery, you still get progression. So this is a group of patients here that didn't get repair at the time of their mitral valve repair. And you can see that the prevalence of moderate and severe regurgitation increases over time. And this was a 5-year study. In fact, those patients who ended up having repair also progressed. And so in the last graph down in the bottom, you see that despite repair, those patients that started with moderate tricuspid regurgitation continue to progress. So this is a progressive disease. And we know that to be true when you look at progression of disease in the CT Surgery Network trials, and there were a number of these randomized trials that looked at mitral valve surgery, that the presence of greater than or equal to moderate tricuspid regurgitation at 2 years was higher if the mitral valve repair failed. So if you had recurrence of the disease, but also if you had pacemakers. And so this was really an interesting finding. This was a very recent study showing again that we need to be looking at our patients that have pacemakers implanted. In fact, if you had progression of the disease over time, then there was a significantly higher likelihood that you would have clinical events. And those events were either worsening symptoms or heart failure hospitalizations, as well as the need for mitral valve surgery or stroke. And so these are patients that were studied in those randomized trials that never got got therapy. And so when you look at the other misconception that we had, it was based on the fact that we knew that secondary tricuspid regurgitation occurs in the majority of patients. And so 80 to 85, this was an older study, were secondary. And secondary meant that they had a lot of other concomitant diseases. And so the misconception was that TR was an innocent bystander. But there were multiple studies, and this is just a review and meta-analysis of various studies that adjusted for those comorbidities, including atrial fibrillation, mitral regurgitation, reduction of left ventricular ejection fraction or pulmonary hypertension, as well as RV dysfunction, and found that despite adjusting for these comorbidities, tricuspid regurgitation portended a worse outcome independently. And so we now know that indeed tricuspid regurgitation does not seem to be an innocent bystander to the other diseases, particularly of the left heart. When you look at natural history studies, all of the graphs look about the same. There's this progressive increase in mortality, the higher the grade of tricuspid regurgitation. And this is a study that looked at 5-year outcomes, whether they were in hospital or out of hospital. And most recently, we have a 20-year outcome from the National Echocardiography Database of Australia. And so this study showed that out to 20 years, they followed these patients, even mild tricuspid regurgitation at the initial echo was associated with increased mortality. And so we do believe that tricuspid regurgitation is a significant player in outcomes. Now, historically, it was always believed that it was the annulus that defined the severity of tricuspid regurgitation. And that makes some sense because the leaflets are obviously attached to the annulus all the way around. And so the initial studies by Giels-Dreyfus showed that indeed a 70 millimeter stretched diameter in surgery corresponded to a diameter of about 40 millimeters from an apical 4-chamber view, and that indeed that when you did a remodeling annuloplasty, you improved the regurgitation irrespective of the initial baseline starting regurgitation. And so the initial anatomic, not misconception, but belief was that annular dilatation was the main determinant of outcomes following tricuspid valve repair. And so this has really been challenged by the recent CT Surgery Network trial, which 400 patients were randomized to either mitral valve surgery or mitral valve surgery with tricuspid valve annuloplasty. And the two criteria were not severe tricuspid regurgitation, but moderate tricuspid regurg or less than moderate, so mild tricuspid regurgitation with annular dilatation. And the outcome was a 2-year endpoint composite of reoperation for TR, progression of TR by 2 grades from baseline, or the presence of severe TR or death. And they obviously met their primary outcome, but it was completely driven by the progression of TR by 2 grades. And the downside to, and that's shown in this middle graph, the downside obviously to repairing everyone is that there was a 14% incidence of a requirement for a permanent pacemaker. And so it's not that everyone should get annular repair at the time of mitral valve surgery. And in fact, when you look at the supplemental data and the analysis, the post hoc analysis that stratified the 2 groups of patients that they looked at, those with moderate disease and those with mild disease and annular dilatation, it turns out that only those patients with moderate disease saw the benefit of a reduction in tricuspid regurgitation progression. And so the difference was completely driven by the moderate patients, and therefore it doesn't seem as though annular dilatation alone in isolation is the determinant of TR severity or progression. Now, this makes some sense because we know that using a single dimension to measure the annulus may not be entirely realistic. It's a 3-dimensional structure, and this beautiful study by Karima Adisha showed that indeed, depending on where you measure it and at what which view you used, you could get dramatically different measurements of the annulus. The annulus was also very dynamic, and you could see that, and this is true of the mitral annulus as well, but that dynamism was part of the efficiency of the transfer of blood from the right atrium to the right ventricle. And that the dynamism, in addition to the dynamism, there were significant differences in size based on sex, and that women ended up having larger dimensions of the annulus compared to men, even when indexed for body size. We also know from other three-dimensional echo studies that the area of dilatation differs depending on what the etiology of the tricuspid regurgitation is. And so in patients who have functional tricuspid regurgitation, mainly ventricular functional, they'll dilate out a little bit differently than those patients with primarily atrial functional disease. And so the area of dilatation is different as well. And so a single dimension probably really doesn't describe the complex nature of the annulus itself. So what about understanding anatomy and pathophysiology? This is where I think we've learned the most because we really fail to think about the tricuspid valve and the right heart as a unit. And so if we start with the leaflets themselves, we found early on, and this was a really early slide that I'd made based on three-dimensional images that we had acquired on all of our patients, that the tricuspid valve was extraordinarily variable. It wasn't always 3 leaflets. And so not infrequently you saw 3, but sometimes we only saw 2, and not infrequently we saw more than 3. We saw 4 and sometimes even 5. And when you look back at the pathologic literature, it turns out that they always knew that. So the pathologist had always seen the tricuspid valve and known that it could be highly variable. This is one with 2 leaflets. This is the traditional 3, but they describe indeed the same thing that we saw, which is 4 leaflets and 5 leaflets, not infrequently. And so we decided to take a group of patients and look at their 3-dimensional and 2-dimensional echoes using primarily the transgastric view. So for 2-dimensional echo, it's the only view that allows us to see all the leaflets at once, and determine how often we saw the different types of morphologies, leaflet morphologies. And we saw 3 leaflets in about 54% of patients, and then 4 leaflets, with the most common being 2 posterior leaflets, in about over 30% of the patients. And these were kind of all comers to 4 different labs, 2 in the US, 2 in Germany. And it turns out that as we move further along in the trials, we found that really the 3 Bs, the ones with 2 posterior leaflets, may be more common than we thought, and not infrequently as common or more common in those patients that are coming to the trials than the 3 leaflet valves. Now, the leaflets are indeed attached to the annulus, and we talked a lot about the annulus. It tends to be a D-shaped structure, so it's really bolstered by and flat along the region of the septum. In addition, there are multiple crisscrossing muscle bands, and so those of us that measure the RV basal dimension from apical 4-chamber views know that there's all these muscles that are toward the base of the valve, and that's in part why the basal RV also controls the tricuspid valve. And then there's obviously the annulus itself, which tends to be virtual on the tricuspid valve side. So this was in the pathology suite at Columbia, and if you were to just close your eyes and run your finger from the right atrium to the right ventricle, you wouldn't actually feel any annulus. There's no fibrous tissue around the majority of the annulus itself. And so it's really almost a virtual structure. And the other thing that we knew from Karima Adisha's study is that dynamism, but the dynamism is also related to the RV function. And so when you look at the tricuspid annular systolic excursion, you see that there's shortening of the RV toward the apex in the end, and by the end of systole, you're really at the maximum shortening. And that means that the annulus, which is working like a hinge, it's on a hinge because it's stabilized by the septum, actually has moved up, and when you open the valve, it naturally will then transfer the blood into the right ventricle as the RV relaxes. And so it turns out that this hinge-like motion and, of course, the saddle shape and the 20% changes during the cardiac cycle really increase the efficiency of transfer of blood from the right atrium to the right ventricle. And when you look at the annular histology, it turns out again that correctly there is from our visual as well as our a tactile sensation, there really is no fibrous tissue, and so it goes directly from right atrial muscle into right ventricular muscle, and this area between the two, the distance where there's very little muscular fibers at all, tends to be in the inferior region of the annulus, explaining somewhat the finding of the three-dimensional echo study that showed that annular dilatation differs among the groups of patients, and that atrial fibrillation tends to dilate a little bit more out the posterior side of the annulus. Now, atrial fibrillation is an interesting problem for the tricuspid valve because it turns out that the annular dynamics that I showed you are extraordinarily important, obviously, in the function of the valve. But blunted tricuspid annular area change and larger right atrial volumes were independent predictors of tricuspid regurgitation. So just the atrial fibrillation discoordinated contraction will tend to increase the severity of tricuspid regurgitation. But are there other predictors of tricuspid regurg? And it turns out that this study looked at a very large population to find out the risk factors for progression to moderate or severe tricuspid regurgitation and to calculate the relative risks of each of those findings. And it turns out that the risks, indeed, the strongest predictors of TR progression were a pulmonary artery systolic pressure as low as 36 millimeters of mercury. So this is a normal pulmonary artery pressure for us. This is still within the normal range. And so the minimally elevated PA pressures may actually predict TR progression. So think about that when you think about heart failure with preserved ejection fraction, for instance, where you may have really minimal increases in pulmonary pressures that then that stimulate or are associated with significant TR. Left atrial enlargement, again, a marker, I believe, for high left atrial pressures. And that makes sense because remember that the tricuspid, the right heart has to transfer the same stroke volume across the pulmonary circulation and the left atrium at the time of mitral valve closure, right? So now we're depending completely on the compliance of the left atrium and the pulmonary circulation in order to be able to transfer that amount of stroke volume. So anything that causes left atrial dilatation, in particular, obviously increased left atrial pressures or atrial fibrillation, for instance, may indeed cause progression of TR. Age is a big predictor of TR, and then, of course, atrial fibrillation. So those four factors really determine the progression of disease. In addition, this study coming out of Jerome Bax's lab looked at how rapidly you progressed with your tricuspid regurgitation. And it turns out that age again shows up, but RV function, so TAPSE, left ventricular function with each 1% decrease in LV function. And so this really ties into the interdependence of the two ventricles. RV systolic pressure, again, shows up as a predictor of rapid progression. And then obviously rapid progression itself was a predictor of poor outcomes. So we do believe that tricuspid regurgitation plays a significant role in outcomes. And one of the typical patients that we end up seeing are ones like this. So this is an 85-year-old female with atrial fibrillation, and she has torrential tricuspid regurgitation in the setting of mild mitral regurgitation, completely normal LV size and function. But this torrential tricuspid regurgitation has now led to, at the age of 85, an increase in the size of the right ventricle with normal right ventricular function. So when you look at atrial fibrillation, it turns out that you can asymmetrically dilate the right heart. And so when you look at a tricuspid annulus and atrial fibrillation in patients that have normal left ventricular function, like the patient I just showed you. The tricuspid annular increase was greater on the tricuspid side than it is on the mitral side. Whereas in the patients that have left ventricular dysfunction, so the ventricular functional group, the patients dilated their mitral and tricuspid annulus at the same rate. So you can see again the difference, a greater increase in tricuspid annulus over that of mitral annulus in the setting of normal LV function, but more equal dilatation of the two annuli in the setting of LV dysfunction. So that really explains, I think, a lot of what we see as atrial functional tricuspid regurgitation. Now, atrial fibrillation, it turns out, has a difference in the prevalence by sex. And so women ended up having long-standing atrial fibrillation with age, much higher prevalence than men. And so there was an increased risk of atrial fibrillation with increasing parity. And it turns out we're going to look at parity and the relationship of parity not only to atrial fibrillation, but to tricuspid regurgitation by using the UK data bank, biobank. And so we are investigating whether or not the increased prevalence of the disease in women may be related indeed to the number of pregnancies. Now, when you look at many studies have shown this kind of relationship with women, but AFib, again, one of the strongest predictors of outcomes, and indeed those patients who develop significant or develop atrial fibrillation, again, have a much higher risk of developing significant atrial functional disease. And so this is just a recent study that was just published showing the 10-year major adverse cardiovascular events significantly higher after atrial functional tricuspid regurgitation develops. Now, this difference with women and men actually has histologic basis as well. And so this is just one of the, there are a couple of studies out there that have looked at the difference histologically in the annulus. And it turns out that men have more myocardial bundles and dense elastic fibers compared to women as far as in their annuli, and that men have greater cellularity, which is possible fibroblastic activity. And this was obviously a pathologic study. And so the belief is that they may actually be able to develop more fibroblast and therefore be able to strengthen the annulus under stress. And so males have, again, more myocardium and elastic fibers, may be able to regulate annular contraction and relaxation better than females who have interrupted and low density elastic fibers and few fibroblastic cells, and therefore may be predisposed to stretching and extension of the annulus. And so it's my belief that this very old graph looking at the Framingham study prevalence of severe TR by age, showing a 4-to-1 increase of a greater 4-to-1 greater prevalence of severe TR with females compared to males by the time they reach their 70s and 80s might be indeed related to the age-related changes with the prevalence of heart failure with preserved EF, atrial fibrillation, and hypertension, and therefore also the reduced ability to reverse remodel. And so again, these are all just theories of why there may be this sex difference in the prevalence of the disease. Now, if we move on anatomically to look at the right ventricle, this is really where things become pretty interesting, because the two leaflets, the anterior and the posterior, so if there are two posteriors, it's the first posterior, are really dependent upon this large anterior papillary muscle that's attached to the lateral side of the RV, as well as to the moderator band. And when the lateral side of the RV dilates, and this is just a transgastric TEE view, where this is the RV alpha tract at the bottom. So this is obviously the liver is now on the top. The anterior papillary muscle here will control the much of what happens to the anterior and the posterior leaflets. And so if you dilate out the lateral side of the ventricle, you're going to obviously pull the anterior and the posterior posterior leaflets away from the septal leaflet. But in addition, the septal leaflet is very unusual in that it has, particularly along the anterior side of the septal leaflet, all of these direct chordal attachments to the myocardium. And so frequently we will see those really dense chordae attaching the septal leaflet directly to the septum, and anything that changes the morphology or location of the septum will then change the location of the septal leaflet. So that happens anytime you have an increase in pulmonary pressures and you cause some flattening of the septum. That will end up pulling away the septal leaflet from the other two leaflets. And so we know now that what happens in the ventricle is also very important to the tricuspid valve. And early on, Jan Topilsky noticed that there were two different types of patients with tricuspid regurgitation, what we now call atrial secondary TR, and this he called idiopathic, but that is the atrial functional disease that's related to annular dilatation. And so if you have right atrial and annular dilatation, now the leaflets don't have enough area to cover the annular area. And this is classic appearance of atrial functional disease, where the RV itself isn't playing as big a role in tricuspid regurgitation as the annulus and right atrium. And then you have those patients, which he called pulmonary hypertension functional TR, which we now know is ventricular secondary TR. And that's where the RV now plays the major role in determining tricuspid regurgitation by dilatation of the mid wall. And so we all know and are familiar with what happens with acute pulmonary embolus. The mid-ventricle of the RV is very susceptible to acute dilatation. And so in that setting of acute dilatation, you're pulling out the papillary muscle that is controlling the anterior and the posterior leaflets, therefore causing tethering of the leaflets. So remember, the papillary muscles are getting pulled out, which therefore means that there's just the chordae are stretched, and the tricuspid valves are now closing in the ventricle, and therefore don't have enough area to cover the ventricular basal area that is required in order to have competence of the valve. And so this is failure of the leaflet coaptation within the ventricle, and that's ventricular functional disease. And so in the New England Journal article, I attempted to at least identify most of the key features that might differentiate the two atrial versus ventricular secondary tricuspid regurgitation. And obviously tethering and right ventricular dilatation, a major player for ventricular disease, atrial dilatation with normal, relatively normal RV size, and therefore the right atrial to RV ratio that is significantly increased, typically greater than 2, would define those patients with atrial secondary tricuspid regurgitation. And when we think about then what we talked about earlier, which is primary versus secondary disease, we now know that this is a little too simplistic. And what we need to do is really separate out the pacemaker related disease out of the primary disease. This ended up being a huge percentage of the patients that presented with primary disease had pacemaker related disease. And I've already shown you that pacemakers are a big predictor of progression of disease. And so they are now taken out of primary and have their own category, remembering that it may not just be leaflets that they impinge upon, but the subvalvular apparatus and even papillary muscles. And then the patients with secondary disease divided now into ventricular secondary and atrial secondary disease. And so the new etiology categorization is, as you see here, the new classification: primary, secondary divided into atrial and ventricular, and then pacemaker related disease, the primary disease being those that actually are causing the tricuspid regurgitation. And there's been a lot of talk about what to do about primary disease of related to pacemakers, whether or not we should be attempting to extract all of those, and be interested to hear anyone's opinion about that. We've not been extracting all of those patients, particularly the ones that are coming to transcatheter tricuspid valve device trials. So atrial secondary disease, how to define it. So the New England Journal article was vague. We didn't put in a lot of numbers in there because I think we're still trying to figure out if there are cutoffs that we can use to strictly define atrial secondary disease. And this is the one, the paper that coming out of Denise Muraro and her lab and with Luigi Badano, looking at the ACC AHA guideline criteria. And this was taken from the paper by Topilsky, who defined atrial structural secondary disease, as AFib, normal LV function, pulmonary, relatively normal pulmonary artery systolic pressures, no left-sided valve disease, and normal appearing tricuspid valve leaflets. Now, we don't believe that they all have to have atrial fibrillation. So this is a very, very strict criteria because we have many patients that we believe have atrial secondary disease or the morphology of atrial secondary that don't have atrial fibrillation. But in any case, when looking, dividing those patients into atrial versus non-atrial secondary disease, there's a twofold increase in 1 year combined endpoints for ventricular secondary compared to atrial secondary. And this graph is really important when one considers the new Triluminate trial that's out there now, because the Triluminate trial, both arms, the medical therapy arm and the treatment arm, are following the mortality curve of atrial secondary disease. They're not following the mortality curve of ventricular secondary. So they have a very low 1 year mortality of 10%, and for both arms. And so consequently, the 1 year follow-up period might not have been enough to determine a difference between medical versus transcatheter therapy. In addition, this study was really important in looking at the predictors of outcome related to the different types of disease. And so when you look at atrial secondary disease, it's truly tricuspid regurgitation that determines severity. When you look at ventricular secondary disease, it's RV function and tricuspid regurgitation severity that determine the outcomes of the disease. And so this is really important because in truth, when we were designing the trials, and there are two ongoing US trials, randomized trials for device therapies, but when we were designing the Triluminate trial came first, we really wanted to isolate those patients that had TR as the primary etiology of their outcomes. And I think that, in all honesty, the trial successfully did that. What we didn't know at the time of designing the trial was that the outcomes of these two disease processes were so different. And that's really, I think, a large explanation, in large part the explanation for the negative, somewhat negative results of the Triluminate trial. So secondary TR is the only parameter independently associated with prognosis for atrial secondary disease, but you have to consider RV function in those patients with ventricular disease. Now, this is a different study that tried to separate out atrial versus ventricular secondary disease based on cluster approach, and they found morphologic as well as LV functional definitions fit the classification of atrial secondary disease. And so tenting height of less than 10 and a mid-ventricular RV dimension of less than 38. And it turns out that 38 probably is the upper limits of what's normal from the large database that of the WAYS trial, which we won't talk a lot about, but it's a large database that is looking at normative values for right ventricular size and function. And so if you have less than 10 millimeters of tenting height, a small, relatively small RV, and then normal LV ejection fraction, that defined atrial secondary. And so here you see again that there's significant difference in outcomes, whether or not you're treated conservatively or whether or not you get transcatheter therapy in patients with atrial secondary disease. So we know now from multiple studies, and this was just one of the first ones, this came out of the Mayo Clinic with Jan Topilsky when he was there doing research, that indeed the atrial functionals, which were the isolated, but we now know as atrial function secondary disease, has a better prognosis perhaps than primary, and that the worst prognosis is those patients with the various etiologies of ventricular secondary disease. So can we predict outcomes? Well, it turns out that various risk scores have been attempted to help define outcomes in those patients who are being treated medically. And this is a large study by Tim Wong that looked at, again, a large, almost 5,000 patients with secondary etiologies and primary etiologies of tricuspid regurgitation, and found that, again, the risk model for all-cause mortality and isolated, so atrial, we believe, or isolated secondary is a little different than atrial secondary disease in this study. This is all secondary diseases. Is age, as we knew, is peripheral vascular and or coronary disease, as well as lung disease. It's renal disease, and it's the extracardiac organ damage that we end up seeing, not only with the kidneys, but also with the liver. And so in addition to anemia and thrombocytopenia. So all of these extracardiac effects of low cardiac output and congestion of the liver and the kidneys. And then it's right ventricular systolic function. So the one that gets the most number of points is severe RV dysfunction. And so we do know, indeed, as many of the studies have shown, that severe RV dysfunction is going to play a role. So all of these things may contribute, and they developed this score for predicting the outcomes, 1 year all-cause death in patients that are being treated medically. And so it's a novel risk score for sure. And it may be one of those scores that we needs to be validated, but we may be able to use when talking to our patients about outcomes with medical therapy. In addition, other studies have attempted to look at phenoclusters and have been able to define various phenoclusters that have poor outcomes. And this study was a little less successful in looking at phenoclusters than the subsequent study. And this subsequent study found that the phenoclusters, obviously outside of the severity of tricuspid regurgitation, so less severe tricuspid had the best prognosis, and then more severe tricuspid had a worse prognosis, but then progressively worse prognosis with, again, ischemic cardiomyopathies, lung disease, and chronic kidney disease. So very consistent message about those predictors of poor outcomes, particularly in our patients with secondary disease. So what do the guidelines tell us to do? Well, the two guidelines are relatively recent guidelines, but at the time of publication, we still had relatively little data out there. And so both of the guidelines discuss medical therapy. And remember that, unfortunately for us, the clinical presentation of tricuspid regurgitation is difficult because the early presentation is so nonspecific. It's a little bit of peripheral edema, some fatigue, and reduced functional capacity. These are 80-year-olds, right? And so not infrequently we say, oh, little edema, let's just, we'll treat with a little bit of a diuretic, and we won't, don't need to look much further. But then once they develop right heart failure, as we've already seen with all the risk scores, they're in really big trouble, and they have very bad outcomes. And so the problem that we have is that the early presentation is nonspecific, and the late presentation has a horrible prognosis. And therefore, how do we treat these patients, and at what point do we intervene? That's still something that we're beginning to look at. And so when you look at the guidelines for what is guideline-directed medical therapy, we don't have any class 1 indications on the US side. There's none. We can't even give a diuretic a class 1 indication. So a diuretic has a class 2A indication. There's no data. And then treatment of all the left-sided disease, as well as atrial fibrillation, gets another class 2A recommendation. So no data. The European guidelines don't want to give a number, class of recommendation, but they tell you that diuretics are useful. Treat the pulmonary hypertension. Please control the rhythm. But because in Europe there are the transcatheter device therapies, the guidelines are very, very clear that in the absence of advanced RV dysfunction, which obviously we believe might be futile to treat, or severe pulmonary hypertension. None of the above mentioned therapies should delay referral for surgery or transcatheter therapy. And so there is a difference in the European guidelines because of the access to transcatheter therapies, but both guidelines lack evidence to guide their therapies. But we all know, I think, clinically, that diuretics do work, and that the real question is, at what point do you intervene? So we all of us treat with a loop diuretic typically first. We may add a mineralocorticoid receptor antagonist as they begin to fail and become diuretic unresponsive. And you can see that the CT scans clearly show that if you diurese, aggressively diurese, you are going to reduce the size of the right heart. You're going to reduce the size of the RV, reduce the annular size. You're going to reduce tricuspid regurgitation. And the problem is that because we know that there are predictors of progression of disease, should we stop once we see that we've improved patients with a diuretic? Or should we just assume, with knowing the risk factors, that these patients will continue to progress? And I think we know that these patients will continue to progress to the point that they become diuretic unresponsive. And that when we're intervening at the point of diuretic unresponsiveness is really too late. And so we really need to understand the algorithm by which we can treat these patients and also when to intervene. Toward that end, we've this paper has been submitted for publication at JACC Heart Failure, in which we propose a diuretic therapy monitoring and titration strategy typically used for acute right heart failure. And this would be exactly what our tricuspid regurgitation patients present as. And so we're hoping that we may be able to design trials that may test out the theory of the use of a diuretic and give it a class 1 indication finally for therapy, but also obviously hoping that transcatheter devices are going to be approved. Now, what about the management of left-sided disease and atrial fibrillation? Well, we have 2 studies now looking at treatment of left-sided disease and the outcomes of tricuspid regurgitation. So we know that with the mitral clip, that we have a significant reduction in the amount of tricuspid regurgitation. And in that setting, when you have a reduced amount of tricuspid regurgitation, or you start with very little tricuspid regurgitation, then you do much better. So those patients that ended up after the clip worsening or having already baseline 3 to 4 plus tricuspid regurgitation clearly had a worse outcome compared to those patients with mild disease. And so we know that if you change your TR after the clip to mild or 0 to 2 plus, then you will have a better prognosis. Now, what about cardiac resynchronization therapy? This is a great study that came out looking at the improvement in TR with CRT. And it turns out that indeed 22% of patients reduce their TR with CRT, related possibly to the fact that you also can reduce your mitral regurgitation with CRT. And so patients with improvement in TR showed again more pronounced right ventricular reverse remodeling and indeed had a better cumulative survival. So we do believe that CRT, and we also believe that all other therapies for left heart failure are going to affect the right side. Now, what about atrial fibrillation? Well, again, numerous studies, but this is the one I'll show you now, state that if you maintain rhythm, whether you do it as active restoration of sinus rhythm or spontaneous cardioversion from atrial fibrillation to sinus rhythm, that you're going to have a better outcome. And what they found was that all 4 chambers, so mitral and tricuspid regurgitation, are going to reduce, are going to regress if you actually have active restoration of sinus rhythm. And so we do believe that it is not rate control, but it is rhythm control that will help us prevent tricuspid regurgitation as well as progression to heart failure and mortality. So the guidelines, again, the European and the American guidelines mainly differ by the level of their class of recommendation. So typically a little bit higher class of recommendation in the European guidelines than the American, but the paucity of class 1 indications is remarkable. We agree that all those patients undergoing left-sided surgery with severe disease should have their tricuspid valve addressed. And in the European guidelines, severe primary TR without irreversible RV dysfunction, those patients should also be considered a class 1 indication for intervention. But other than that, there's a lot of class 2A and 2B recommendations, many of them hinging on whether or not you have right-sided RV dysfunction or dilatation or severe pulmonary hypertension. So I'm not going to review these algorithms, but just to say that when we're identifying the best candidates for intervention, we obviously want to look at the severity, but we must look at right heart size and function. And then, of course, in order to determine the best candidates for which intervention, we have to characterize the valve, which we've already done in the prior slides. And so to do the severity, to quantify severity of TRs is pretty tough. There's a huge reliance on PISA. The European guidelines, which are more recent than the US guidelines, obviously state quantify whenever possible. But most of us are relying clinically on PISA. And the issues obviously are many, because majority of the guidelines are spent talking about things like structural abnormalities, qualitative Doppler, semi-quantitative Doppler, and very little about quantitative measures of severity, relying heavily on PISA. And so the main issue that we have with tricuspid regurgitation, and why all of these semi-quantitative and qualitative measures can't possibly describe this disease, is what you see here, which is that tricuspid regurgitation from a septolateral 4-chamber view is going to have typically a narrow vena contracta, whereas the majority of the vena contracta is along the anterior-posterior dimension. Because, again, of all those things we discussed, such as the dilatation of the lateral side of the RV or the pulling away of the septum, and therefore everything down the middle from the anterior to the posterior leaflet adjacent to the septum is going to regurgitate, as in this example. And so a single vena contracta from a septolateral dimension isn't going to help us describe what's going on in the AP dimension. We believe from our core lab that our data shows that if you use both a min and a max dimension, that the cutoff should be closer to 9 millimeters instead of the 7. But you do have to average the min and the minimum and the maximum dimension. Now, we also rely heavily on color flow Doppler, but remember, we are dealing with a lower pressure side than on the mitral side, whereas the guidelines give us the same criteria. 10 centimeters squared is the cutoff for severe tricuspid regurgitation. But look what's happening here. We have rapid reequilibration of pressures because we've got really high right atrial pressures. And in addition, we're dealing with a very low pressure side. This is, this is just pitifully low. It's only 2 centimeters. 2 meters per second here. And so remember that the color Doppler jet area is dependent on momentum. And because it's a low momentum side, you're not going to see the same amount of color Doppler jet area that you would see on the mitral side for the same size hole. So color flow Doppler, the European guidelines are very clear. That should only be used to tell you that there is tricuspid regurgitation. It shouldn't be used to quantify the severity of the disease. The color flow imaging should only be used to diagnose the presence, and then a more quantitative approach should be applied. And that quantitative approach in the guidelines includes obviously looking at the vena contracta, but measuring it by PISA or by 3-dimensional echo. And so, and then finally, obviously, also you can use CMR. So quantitation doesn't have to rely on PISA. We are heavily using 3-dimensional echo. And the other measure that we are using is not just color Doppler, but is a quantitative Doppler, which we'll cover in just a second. So let's just review, sorry about the slides, but PISA. And you can see again, the reason why PISA may underestimate is that it's an ellipse. And so it doesn't really satisfy any of the assumptions of PISA with tricuspid regurgitation. So it assumes there's no temporal variability, and we know there's almost always some temporal variability. It assumes it's a round hole, and we know that it's a very complex hole. It assumes a flat surface, and remember, 80% of patients have ventricular or secondary disease with tethering. And then it assumes that the aeosine velocity is significantly lower than the peak velocity. And the tricuspid regurgitation side, that's just not true. And so all of the assumptions fall apart. We've looked at correcting for flow, angle, and shape, and found that we are able to increase the PISA to the point where it is equivalent to, with no significant difference with three-dimensional vena contracta area. So again, easy to do. We love to do PISA because it's so easy. There's lots of disadvantages and obviously pitfalls. And so maybe it doesn't represent the true regurgitant orifice, but it sure is a determinant of outcomes. So PISA, EROA, these are 4 studies that have determined outcomes based on PISA, and these are most of them are uncorrected PISA measurements. And so when you quantify all patients by PISA, we are using 30 to 35 millimeters squared to say that, oh my gosh, it could be severe. Let's refer those patients to a valve center that has some expertise in other measures of quantifying other measures of severity. And that includes 3D vena contracta area. So these are transthoracic echoes looking at vena contracta area, showing again that we are indeed able to measure the actual area, and we like to integrate it over the systolic time interval. So we're trying to account for temporal variability by actually adding together every frame of systole and then dividing by those number of frames in order to get at the truth. And so we do believe that there's growing evidence that PISA, EROA, and 3D vena contracta area are very closely associated, and that 3D VCA may give you the true severity of disease. And we know that based on that PISA underestimates 3D VCA by about 40%. So again, use all your methods. It's an integrative process still, but we like to use the quantitative measures of not the semi-quantitative, but the quantitative measures of PISA and 3D vena contracta area. So the missing piece is that we're exploring in the core lab volumetric echo, volumetric Doppler, just like on the mitral side. And so I don't want to go over that now because it's I can certainly talk about it with anyone who wants to, but we've already shown that the 3D VCA and the Doppler EROA are really, really closely associated and give almost the same numbers. And so given our core lab for all of the trials, except the TriScend 2, we are not the core lab for the TriScend 2, but for the 2-tier trials, we are using all 3 methods of quantitation. And of course, you can use CMR if you feel that you're still unsure about the severity of disease. So right heart failure becomes a big issue. I'm sorry that these are playing so funny. But one of the main issues is that these are the patients that present to us, the ones that have massive dilatation of the right atrium and torrential disease. And that's why we went ahead and increased the grading of severe to severe, massive, and torrential. So if you use a 5-grade scale, it's 1, 2, 3, 4, 5 as you go across. And that has been used, the increasing hazard associated with grades greater than severe have already been shown in multiple studies. And so including the early feasibility trials, this is the Triluminate early feasibility trial that showed that the ability to get yourself down to mild or moderate disease was significantly predicted by the severity that you started with. So if you have torrential disease, it's really hard to get yourself down to moderate. In addition, using just a single grade reduction, we know that we can affect the way the patients feel, and this is exactly what the Triluminate pivotal trial showed. But we also have seen from these other studies that, again, torrential disease is associated with less procedural success. But if you have procedural success with massive or torrential disease, you will affect outcomes. You will improve outcomes. And so that's what this beautiful study showed. Those were from the supplemental tables. So again, I don't have to beat this down, but those patients, again, that are able to reduce by 2 grades using a 5-grade scale, or by 1 grade without pulmonary hypertension, are going to do better. So we need to really understand how to grade TR in order to understand what outcomes are important to patients. And these are all the trials that have already used the 5-grade scale, and therefore the European guidelines state that you can use the 5-grade scale, particularly in those patients that are going to tricuspid interventions, in order to not only predict how the ability to get those patients down to mild or moderate or less, but also to determine perhaps the outcomes of those patients. And so we do believe that the 5-grade scale has utility. So assessing right heart size and function. It's hard to spend the next couple minutes on right heart size and function, because that's really one of the main things that we need to do in our tricuspid valve patients. But this is a recent review article that was published, and I refer that on multimodality assessment of right ventricular function. So I definitely refer you to that article. But echo, we know all these parameters become extraordinarily important. And so we're looking at the size, obviously, of the various dimensions and eccentricity or sphericity index, and then looking at fractional area change, TAPSE, systolic TDI, strain imaging, and almost most importantly, 3D volumes. So now that we have automation of 3-dimensional volumes, we should be able to use 3-dimensional EF in many of our trials, and it's currently missing in the trials that we have ongoing now. So the utility of all of these other measures are clearly being used, and are associated with outcomes, which I don't have to show everything, but TAPSE clearly is associated with outcomes, as is strain. And so this is a study that shows that strain has incremental benefit in determining outcomes over fractional area change and TAPSE. But it is indeed the 3-dimensional echo volumes that we believe will in the end help determine outcomes. And so these are all automated now, with obviously some need for adjustment of the outlines, but with relatively minimal adjustment, we've already been able to show that RVEF of less than 45% by echo or CMR, the same cutoff, predict outcomes in patients with tricuspid regurgitation. We can also look at those patients by CT. And so these are just studies looking also at CT-EF, which are also powerful, and the ability now to be able to look at strain imaging in 3 dimensions also. So this is just a look at TEE before tricuspid intervention, and then this is after putting in a tiered device, and you can really see the change that is occurring in the strain of the RV, and this may be able to help in the 3-dimensional strain give us a better idea of function. And toward a better idea of RV function, we also believe that ventricular arterial coupling, so RV-PA coupling, is going to be important. And usually we measure it invasively as the ventricular end systolic elastance over the arterial elastance, so EES over EA. But there are many ways of estimating RV function indexed to afterload or PA pressure, and that's RV-PA coupling. And so some of those, obviously pulmonary hypertension, very important. I'm going to skip this study to talk more about RV-PA coupling, but pulmonary hypertension, clearly an issue. So those are studies looking at pulmonary arterial, and this is pulmonary venous hypertension, both predicting outcomes, but it's really RV-PA coupling. And so this is a study that looked at the discordance between invasive and echo measures of pulmonary pressure. And the hypothesis was that this might be a surrogate for RV-PA coupling, but we can also measure directly the TAPSE over PASP. And this is a study that showed in medical therapy, medically treated patients, that TAPSE over PASP with a cutoff of 0.31 predicted outcomes. And then this is the study that we did from the TriValve registry, showing again that TAPSE over PASP, and these are all echocardiographically estimated, also determines outcomes. And so I'm not going to go over the pathophysiology of it. I'm going to skip this, but just to say that TAPSE over PASP, whether you measure PASP by echo or in this study invasively, determines outcomes. And so we do believe that there will be measures of RVPA coupling, and all of these have been used. The one that I like, and there's a new paper coming out, is stroke volume divided by end systolic volume. This has been directly correlated with EES over EA, over invasive. It's been directly correlated with, in the past, with invasive measures. And so lots of the WAYS study is really going to change the way we think about what normative measures are. And so these many of these numbers are now going to go into the TVARC document, and understand that there are other multiple ways that we have of measuring RV function, including CT and CMR. So with that, we're getting toward the top of the hour, and so I'm hoping that we don't really have time to discuss all the therapies. What I might do is just skip very quickly to some of the transcatheter therapies, and really end on this slide. We know that the 3 randomized trials, the Illuminate trials, already been published. Pascal, or the CLASP 2 TR trial, is still enrolling, and the Evoke trial has pretty much fully enrolled, and the outcomes will be available soon. And so we hope to learn more about tricuspid regurgitation from these randomized trials where there's a large medical treatment group. Thanks for your attention.
Thank you, Becky. It was an amazing presentation. So maybe we can take a few minutes for questions. We have Pascal.
Thank you for a fabulous presentation. I wanted to ask you to discuss the difference between the RV functional TR and atrial functional TR. You've really highlighted the differences in outcomes between those patients, and how often one of the determinative outcomes is ventricular functional TR, maybe more than the ventricular function itself rather than the severity, or in addition to the severity of the TR. What are your thoughts about that group of patients, and whether transcatheter therapies will be effective in that group of patients if their outcomes are also related to RV function?
Okay, it's very hard to hear the question, but I think the question really is related, and please, David, tell me if I'm wrong, related to whether we'll be able to treat ventricular secondary disease, given the various comorbidities. Is that about?
That's correct.
Okay, and I think that the other trials, you're 100% right that we designed the trials, unfortunately, for atrial functional disease, because we didn't want to have to deal with the morbidity and mortality associated with ventricular functional disease. But I think that there will be differences in the patient populations of the other 2 trials. So the CLASP 2 TR trial might also still have more atrial functional disease, but has been a little bit more lenient about the peak PA pressure that is allowed into the trial. It was more lenient about the pulmonary vascular resistance cutoff, 5 Woods units. I mean, that's pretty darn high. And so there are differences in the trial inclusion criteria that we may end up seeing differences in outcomes earlier on. And remember that the CLASP 2 TR trial is a 2-year endpoint, not a 1-year endpoint. So again, we are hoping and we believe that a longer follow-up might be needed for some of these patients. The patients in the Evoke trial are also very different. Similarly, some of them are very sick. Remember, these are the patients. In many of the cases, we have a number of centers that are enrolling in both, because they're both Edwards devices, both enrolling in both the CLASP and the Evoke. And they would preferentially, and this was probably consciously and sometimes unconsciously, enroll the small gaps into the class because you could grab the leaflets, and the big gaps, so the horrific torrential disease, into the EVOKE trial. And so my guess is that we will also see a difference between those two trials in the severity of disease. And the more torrential the disease, the later in the disease phase you are. And therefore, even if you started as atrial functional disease, you now have components of ventricular functional disease. And so I do think that we will have some answers from those trials.
And one small question related to that. You related to Triluminate, Becky, which showed relatively neutral results, a little bit disappointing. We have heard from that trials many comments. One was that the enrolled patients that were too severe in the disease. Some people were saying they are too early or not too severe enough to see any impact on outcome. What is your view regarding the population that has been enrolled in Triluminate?
You know, I think that those that argue that are not wrong. So when you look at the early feasibility trials, not only was the age much older, so only about 76. I may get some of the numbers wrong. Mean age of around 75, 76 in the Triluminate versus like 86. In the early feasibility trials. These are patients further along in their disease process. Remember that the mean gap size, the septal lateral gap size, was 5. So that's again, possibly earlier in the disease process. New York Heart Association class in the early feasibility trials, class 3 and 4 in 75% of patients, not so in the Triluminate pivotal trial. So I think that there are many arguments that would support the contention that perhaps the Triluminate trial, and remember we were initially very early on. I mean, this was it. This was the one trial, and tricuspid regurgitation patients were just kind of pouring in, and so they had their pick of ideal patients that they thought they could get down to moderate, and so I do think that they ended up with a patient population earlier in their phase of disease process compared to the early feasibility trials. Therefore, somewhat determining the very good outcomes that they saw, but in both groups.
It's 8:35. I think we have to close. Stay with us for the meeting with the resident. I think we have to close that session and open a new one. But I would like to thank you again, Becky, for this fantastic presentation. Thank you.
Thanks for having me. Yeah.